for those of you that are eagle-eyed, I was going to say I'm not Emma Ross. Emma was supposed to be presenting today, but unfortunately couldn't make it, so I've stepped up to present in her place. Although after listening to Dermot's talk, I don't think there's any point presenting anything to do with suicide data because we don't trust any of the statistics. But I'm going to talk very briefly about some of the work that we've been carrying out within our group exploring suicide following self-harm in young people in Northern Ireland, and we're using the Northern Ireland Registry of self-harm data for this linked to mortality records. So for a bit of background, suicide is the second leading cause of death in young people worldwide, and self-harm is recognised as the biggest predictor of suicide. And we know self-harm is most common in very young people, especially those aged under 24 years. The true estimates of rates of self-harm are varied, tend to be based on self-report measures and surveys. Increasingly, we're beginning to look at hospital presentation statistics as indicators of self-harm. But again, this will be an underestimation of true self-harm, as not all self-harm results in a hospital presentation. There's a dearth of studies examining self-harm and mortality risk, particularly in young people. So studies to date have looked at whole populations or large surveys, which have just surveyed the adult population. But when we're trying to look in particular amongst young people, survey data is left with very small numbers. So administrative data will help to sort of unpick that. So the aim of this research was to characterize who presents with self-harm, to quantify the risk of suicide and other causes of death following presenting with self-harm, and to identify within those who present, are there any particular factors that are associated with the greatest mortality risk. And for this study, we used data from the Northern Ireland Registry of Self-Harm and Suicide Ideation. This data is, which you can see in the top left corner here, and this presents information on all presentations to emergency departments across the entire Northern Ireland, across all 12 hospitals, for self-harm and suicide ideation. So even if you haven't harmed yourself but are presenting with ideas of suicide. This population-wide register began in about 2012. So we're looking at data from 2012 to 2015, linked to primary care registration data, prescription medication data, mortality records, and then standard sort of area level variables of deprivation and measures of urbanicity. So Dermot's already gave you quite a good overview of Northern Ireland suicide data, and basically what that means is that for this analysis, we're going to look at just those that were definite deaths of intentional self-harm. So that's your codes X60 to X84. And we're including, like Anne suggested, we're using undetermined intent as sensitivity analysis. So in the cohort, we had 390,000 young people aged 10 to 24 years. Of that, 4,450 presented with self-harm during the study period, so from 2012 to 2015. That's about 1% of the population. During follow-up, we recorded 676 deaths. 155 of these were the result of self-inflicted injuries or suicide. 98 of the deaths were in individuals who had presented with self-harm at some point over the study period. And 38 of those were due to self-inflicted injuries to suicide. So 35% of the deaths in young people who presented with self-harm were due to suicide. And what that meant globally was that 23% of all deaths due to suicide were in individuals who had previously been seen in emergency departments for self-harm. The idea is this is a possible opportunity for intervention. So just looking briefly at our cohort in terms of who's presenting with self-harm and who's most likely to present with self-harm. And this shouldn't be a surprise to anyone here. We see that self-harm presentation increases with age. So we're seeing higher rates in young adulthood compared to very young children. See men are less likely to present with self-harm than women. And we see increases in self-harm in those from deprived areas and those from urban areas. And urban areas may have to do with proximity to hospitals, but we'll include it as a factor. When we look at risk of mortality associated with self-harm, this table shows the results of our Cox proportional hazard models investigating the risk of all-cause mortality due to or based on self-harm exposure. And then we also looked at external deaths, which are really that sort of possible suicides, but also including accidents and drug-related deaths, and then self-inflicted deaths, which are really suicide, but not that's how we normally coded it. And what we find here is that in the adjusted models, individuals who present with self-harm are 11 times more likely to die at all than young people who don't present with self-harm. They're 17 times more likely to die of external causes of death and 19 times more likely to die by suicide than those who don't present with self-harm. Taking a look at presentation characteristics of those who do present with self-harm, most self-harm is due to drug overdose. That's either prescription medication or non-prescription medication. About a quarter of self-harm is due to cutting with a sharp object. And then the other 7.5% is made up of jumping from a high place, strangulation, drowning, etc. And there are some queries around the differences in these methods of self-harm, in that sort of other category, maybe less self-harm and more attempt to take your own life. But it's difficult to sort of disentangle intent really here. Almost half of individuals arrived by ambulance. The rest were either arrived by self-referral or by police. Only 22% received a psychiatric assessment whilst in the emergency department. Now, we are told that everyone gets offered a psychiatric assessment, so we're not sure whether it's just not recorded correctly in the data, or if individuals who don't receive a psychiatric assessment are those who arrive at emergency departments unresponsive and unable to take part in an assessment. But half are admitted, and around 30% have more than one presentation. So looking at mortality following self-harm, of the 4,400 people who presented with self-harm, 98 died during follow-up. 80 deaths were due to external causes, which really means that most of the deaths were preventable. 35 were due to self-inflicted injury or suicide. We can see the rate of death for due to self-inflicted injuries among self-harmers is quite high, 118 per 100,000 years, compared to 5 per 100,000 person years with no recorded episodes of self-harm. What was of interest also was sort of proximity to self-harm, in terms of, was the mortality risk higher in the first year after presenting with self-harm, second year, third year, etc. What we found was that mortality risk is highest during that first year after presenting with self-harm, but it does maintain up to 3 years after presentation. So this graph shows the incidence of death as a result of self-inflicted injuries, which we'll call suicide. The same can be seen for all external causes of death. So there's just a higher risk of all mortality after presenting with self-harm. When we look within the self-harmers, we want to ask, well, is there anything in particular about these guys that are associated with an increased mortality risk? And what we find is that actually men are more likely to die by suicide after presenting with self-harm, even though women are more likely to present with self-harm. What's interesting is that deprivation and an area of residence doesn't seem to have an effect on suicide risk. It doesn't matter where you come from if you're a self-harmer, that won't help determine whether you're more or less likely to die after presentation. What we do find, though, is that individuals who present more often have a higher risk. We're bordering on significance here because of low numbers, but also individuals in that other category, so aren't self-poisoning and aren't self-cutting, have the highest mortality risk after presenting with self-harm. And when we do sensitivity analysis, not just looking at self-harm related deaths or suicide deaths, but also looking at all external causes, the same associations exist. So basically what we're saying here is that individuals who present with self-harm have an increased risk of mortality, that over 1 in 5 of all self-inflicted deaths in young people in Northern Ireland were individuals who had presented to a hospital with self-harm. There's an opportunity for intervention here. And of those who present to emergency departments with self-harm, it's males and those who self-harm through this other category, so more violent methods, that seem to be at an increased risk of death. So this seems to be the first individual level whole population study of self-harm and suicide in the UK. The findings highlight the importance of reducing self-harm, not just in suicide prevention. but in terms of understanding self-harm presentations. Like Dermot had mentioned, it's important to consider accidental deaths and other undetermined intent deaths. So I think in terms of how we classify mortality moving forward, in this study, it may be of interest to take into consideration what Anne had mentioned about looking at, definitive suicides versus possible, probable, and possible. I would like to thank the BSO for their help and support, and I'm sure she's sorry she couldn't be here, but hopefully I'll present it okay and be able to answer any questions. Thank you.
Aileen, thank you very much indeed. We've got a few minutes before our break, so if I can encourage people to put any questions in the Q&A or in the chat box. We have a couple of questions come in. One on, this is a study of self-harm in younger people, Aileen. Is there much difference between the patterns of self-harm in younger people or the outcomes for people younger people who self-harm compared to their older peers?
Very good question. I don't think the analysis has been done on that yet, looking separately at just older people. When we look at sort of younger people as a standalone compared to previous analysis, which has grouped everyone over all self-harmers, so anyone aged 10 to 90, then it seems that the risk in younger people is much higher compared to looking at everybody individually. But I think the next step would be to look at self-harmers in those that are sort of younger adults, middle-age group, and older adults. The older adults who self-harm are also of particular interest, as in Northern Ireland we're beginning to see increased numbers of older people presenting with self-harm. So I think it's vitally important that we don't look at them as a homogenous group, but separate out as the behaviours may differ across age groups. Unfortunately, haven't done that analysis yet, but definitely something to look at.
The second question is, you mentioned that deprivation doesn't seem to be important in predicting subsequent death for these guys. Why do you think that is? What do you think is going on with that?
I think it's hard to find any particular variables that are associated with an increased risk of suicide, like definitively. So we have deprivations associated with an increased risk of self-harming, so increased risk of self-harm behaviour. But of those that self-harm, I think deprivation isn't a predictor of your intent to take your own life. I don't know what's going on there. Happy to take information from the floor about that. What do you think is going on, Dermot? I honestly don't know. I think just it's more looking at, well, individuals who self-harm, who go on to take their own life. It may be less self-harm and more attempted suicide that we're seeing in their presentations. And what does this mean in terms of risk?
You wonder whether there's something about access and presentation and attendance there, because deprivation's also associated very strongly with suicide. So it's very counterintuitive what you found. So to me, there's potentially something there about how people are using services, isn't it?
Yeah, but I think what's interesting, especially, I don't know, in Northern Ireland, the more urban, more deprived areas tend to be closer to hospitals, in that you would see less presentations from more affluent areas. And it may not be that we're seeing more service users from affluent areas presenting with self-harm. People from deprived areas aren't.
There's a paper we did in BJ Psych looking at this the other way around, looking at people who took their own lives, their contacts with services in the year before they died.
Yeah.
And I can't remember that off the top
I think a similar paper has been done in Northern Ireland again, I think by Siobhan O'Neill.
So it might be worth going and looking at that to tease out what the explanation might be.
Can I ask, Sarah asked the question, do you see any cultural variation in the methods of self-harm or links between methods of self-harm and later suicide? Sarah, I'm not sure what you mean by cultural variation. Are we, Sarah, if you want to come online and or open?
Sure.
Yes.
It may, Northern Ireland as a space may not have the extent of cultural variation. I was just been reflecting on a couple of while you've been talking, and by the way, that was an excellent follow on from Dermot. I would have struggled to follow that, but you did brilliantly. I've been reflecting on a couple of things that I've been hearing from different contexts about how behaviours with an intention of harm can look very different in different cultures around the world, and even within different cultures within the same. I don't simply mean ethnicity. I mean culture as a factor within different areas within a country, as well as different cultures across the world. And I just wondered if you'd had any insights of that, but you may not, because your data may not show it.
I think I can answer that one if you didn't count. It's what we.
Sure, go ahead.
This is a tag contest. We haven't done it yet, but we are going to link our data with the census, which gives us, well, for us, culture oftentimes in Northern Ireland is related down to religion, and religion, of course, is associated with suicide. But interesting to see whether religion, Catholicism should have a lower risk of suicide, but does it also hold for self-harm, or indeed translation of self-harm into suicide? So by linking to the census and getting more information on religion and perhaps other ethnicity and migrant status and other aspects as well, we'd be able to throw more light on cultural aspects. Yeah,
and just to sort of add to that, Dermot, this particular bit of research that I presented on is looks only at young people, but within the self-harm registry as a whole in Northern Ireland, when we look at the whole population, this looking at young people, we see more women present with self-harm than men. In Northern Ireland, when we look at the country as a whole, there's equal rates of presentation between men and women, because what we see is an awful lot of middle-aged men and older men are now presenting with self-harm. And talking about cultural differences, there are thoughts that this may be related to historical consequences of troubles, violence, etc. So we always look at things from a Northern Ireland in particular context. And when it comes to young people, the presentations are quite similar to the rest of the UK, but when we look at self-harm in older age groups, definitely those sort of cultural implications.
If I can, just before we wrap up, any word on what COVID has done to self-harm rates in Northern Ireland?
Yeah, so I think McGann mentioned before, we see a massive drop, and we've only been able to look with the registry at raw numbers, not at particular groups. What we see is about a 60% drop in presentations, which hasn't recovered yet. Whereas I know that there are research from the Republic of Ireland which showed a massive drop for the first 2-3 months of lockdown, and then presentations seem to have recovered to as expected rates. But in Northern Ireland, we're still seeing less presentations.